right, we are live. Everybody still with me?
Yep.
Okay. So first, a couple of housekeeping things for those of you who weren't in the lecture Thursday. My name is Krista. Everybody calls me Ducky. I have worked in emergency services for about 12 years now. I've been a paramedic for 6, worked as an advanced EMT for the 6 before that. Like I said a moment ago, all over the country. Well, the eastern side mostly. Everybody still there? My thing just flashed out.
Yes, ma'am.
Yeah.
I think it was trying to connect to the lecture. So, is there anything that any concerns anyone has so far about any of the material? Is there anything we need to go over? Anything y'all want done differently? Let's start there.
I'm good.
Everybody, you feel like you have a pretty good understanding? Okay.
For the most part.
All right. Would anyone be interested in a live, a live class day to go over some skills and go over anything that people feel like they need a little more help on?
You mean live as in remote or live as in person?
As in person.
Depends on where you're at. I'm a good ways away from you.
I'm in Poplarville, Mississippi. Well, that's the closest town to me anyhow. But I can go wherever people can get to.
Hey, I'm sorry to interrupt. Can I add something into your recording?
Yeah.
Thanks. So I just want to let everybody know, and I'm going to tell this to the basic class too. I know that 20 minutes is a tall order for the test that you guys have been doing, so I increased the time limit to 30 minutes. Hopefully that will help. And then remember, if you have a problem with the test, you get 2 attempts. If it's something outside of the curriculum, say like you get a call or a tech issue, that attempt doesn't count. So if it happens 20 times, you get 20 attempts. Just keep that in mind. I don't want you guys to freak or worry about your tests. Just keep up with them is the big thing. That's all.
Oh, well, while you're on here, I know you guys are very used to watching the recorded lectures. Try and actually tune in, because that way you can ask questions, you can get a deeper understanding. If something doesn't make sense, you're in the lecture, you can ask right then. Because I know sending an email later doesn't always happen. Are you there?
We're there.
Yeah,
I heard you.
I'm muted because I'm running, and I don't want you hearing me coughing and gasping on the air. But
Are you done?
yeah, and keep in mind too, I know that Kristen doesn't have Facebook, but you guys are all in that Facebook group, or you should be. If you're not, let me know. And you can always reach out to us there as well for questions that you may have that you didn't get to ask in the live lecture. But yes, I'm here. I'm just muted.
Oh, okay. And I gave everybody my phone number last week and my email address. If you ever need anything, you're welcome to text. Don't call. I won't answer usually. Because I'm either working or I don't hear my phone. But text me and I will text you back, email, whatever you need. All right. You guys ready to start with vascular access?
Hey, Ducky, you had asked about skills. I'm fine with that as long as we have some advance notice, and it's preferably not during the weekday because those are not good.
Okay, yeah, absolutely. About how much advance notice do y'all want? Because
yeah, right now my weekends are booked through the first of the year because I'm doing. I'm sorry, not first of the year, 1st of March because I'm doing ride alongs, but after that I'm pretty good.
okay. All right. Not.
Let me sorry, not to interject on you again. This is specifically for you, Donna. With you being past this chapter, by the time you get on the ambulances, you can have them go over some of your advanced skills as well to kind of give you a head start. I know you've got experience as a paramedic, so this isn't really new to you, but it may have been a while. So, you know, if you want to see if they'll add that in, then it's cool with me.
Yeah, I thought about asking them.
Okay. You forgot to mention that last week when we were talking about that boat. Okay. Yeah, I'll look and see what days are good. And I will have him put it out in the Facebook page.
Hey, Rob, is there another Facebook page for this class, or I'm just on the old one from the last class?
Yeah, no, there's one for each class. I probably dropped the ball on moving you over. It happens a lot to me. So I'll double check that and get you added tonight.
All right, thanks.
If everybody will shoot me their info, I will add you to a group me. A group me messaging thing. All right, so let's get started with chapter 13. Can everyone see the PowerPoint?
Yes.
Okay. So we went over pharmacology last week, kind of touched on it in a little bit more broad manner. This half of it is more as it applies to what we are giving the patients. Like I said, part of the EMS code of ethics is in every healthcare field is first do no harm. There is nothing we can do more harm with than some of these medications we are giving. Especially in an emergency status where the patient may not know any better or living in the deep south. So what are some routes of administration? Oh, hey, Michael. Nice to see you. I like it. We've got IV and IO so far. We've got oral. What else? What do you guys have? Oh, it's usually the first one I get. Yep, there it is. Rectal, subdermal, intradermal, inhalation. If you want to get these meds, there is a million ways to get meds into somebody. We can skip over that. So, what is the first drug that will be in your scope of practice as an advanced EMT that comes to mind when you think about emergency medications? O2, absolutely. Oxygen, because even though we breathe it every day and we're filled with it, it is a drug that can have both good and bad consequences. What else you got? Boys, don't be afraid to chime in. Epi, absolutely. What are the two different kinds of epi?
It's kind of hard. Are you talking about like racemic, or are you talking about the 1 to 1,000, 1 to 10,000?
You're absolutely right. 3 kinds.
One of the two, or 3.
I do that medic math, you know. There's 3 different answers to a 2-part question. So does everyone know what racemic epi is? Awesome. Hey, I've had people tell me they didn't. That brings us back to routes of administration. Epi is a very versatile drug. It can be given IM, it can be given IV, it can be given down ET tubes if the patient is intubated, and it can be given through a nebulized treatment. And it works great no matter which route you give it in. It's often a last-ditch medication because of how great it works. It kind of overpowers everything. We'll go back to the old saying, it can give a rock a pulse. So we've talked about names and routes. Just touching really quickly on effects and indications. Effects are not what we hope will happen, but what will happen once we give that medication. We touched on this last week as well. If we are giving racemic epi, what effect are we hoping will happen?
Decrease respiratory distress.
Absolutely. What is a side effect, a different type of effect, side effect, that is going to happen to that patient that we don't really want, but we put up with it because of the positive contribution it is making to the patient's breathing?
Increased heart rate.
Absolutely. What else?
Increased blood pressure because of the heart rate.
Absolutely, which, yeah, not with the racemic, but sometimes with epi drips, that's something we're actually going for. What else? Anxiety? Absolutely. It can cause them to start sweating. Sometimes it can make a conscious, scared patient a little bit combative. We've seen that happen. Talking about a medication that is very in right now. What about Narcan? What is the positive effect Narcan does for us? I'm really hoping that's a delayed response.
It binds with the same receptors that the opioids does, but better. So it counteracts the opioids.
What do we see? What do we physically see happening with the patient?
Oh,
the good side.
Their rate of breathing should increase.
Yep, and their level of consciousness and their heart rate. Which, we're touching on indications here too. What are the negative effects?
They'll wake up and kick your ass.
That's definitely one of them for the 5'1" girl. Absolutely. What else? Oh, Donna, I love how you put that. That was so sweet. It is very short-lived. A patient in cardiac arrest that you get back with Narcan needs to go to the hospital because that Narcan can sometimes last for as little as 30 to 45 minutes, depending on what drug and how much they took. So you'll be going right back out there to take them back to the hospital, or to take them to the hospital. And it's more work on you and more dangerous for the patient. What else happens?
Keep in mind too, if your patient is overdosing on opioids because of a actual chronic condition that they were prescribed, it's not it wasn't recreational drug use. If you hit them with Narcan and wake them up, if you're having to fight pain after that, your fentanyl or whatever you're giving them is going to be reduced because of the Narcan in their system.
Yeah, we see this in car wrecks a lot. Heroin, it seems to do okay here lately. I don't know what they've got mixed with it. Which reminds me, just to briefly touch on it, please, please, please do not touch a patient or any of their belongings without your gloves on. You do not know what you will be touching. Okay, so there's still one really important side effect I'm looking for Narcan. Everybody give up? It causes vomiting, which in and of itself is a bad side effect because nobody wants to be covered in vomit. The patient doesn't want to be vomiting. But it also creates a very high probability that the patient will aspirate. Aspiration is very bad. Patients get infections from it. They end up septic. They have more trouble breathing, and they're not awake enough to protect their own airway because we're not giving them enough Narcan to fully wake them up. And it only takes a little bit to start them vomiting. However, you also have to think of your safety, so I'd rather be covered in vomit than being beat up where I can do nothing for the patient. All right. We're going to come back to dosages in a minute. We've been over how some of these meds work, and complications and side effects. Contraindications. That is usually a condition the patient has or a medication that they're taking that will cause the medication we are giving them to not work. We see it in STEMI patients. What is a contraindication to giving nitroglycerin? Hello?
I draw the blank, but ED
Low
medicine.
blood
Inferior or right-sided?
That is certainly one. Why is that a contraindication?
Because it affects preload too much and that side of the heart's already weakened, you can crash your blood pressure even if it's over your golden number.
Yep, absolutely. How are you going to know if the patient is having an inferior or right-sided heart attack? And I'm not talking to Rob. You better know. So how are you going to know? What is going to make you say, ooh, I think that might be something I don't need to give nitro for? Okay, I'm going to make a mandatory coffee rule before class. There we go. Okay, but you're advanced EMTs. You're not up to doing EKGs just yet. Well, I guess you are, Miss Donna, but typically. What else are we going to look at? Absolutely. What else? It's the first thing you do when you access that patient. Okay, so not so much airway. We're going to look at their blood pressure. Typically right-sided or inferior, they're going to have a lower blood pressure, which is we don't need to be giving nitro anyhow, because it's going to drop their blood pressure. Any drop of more than 10 points, no more nitro. I am a big fan of nitro paste because if it goes on and we have an adverse reaction, we can wipe it off. A lot of companies have quit carrying it. Make sure if you do give nitro, you're getting a blood pressure before and after, and you're making sure it's a patient that can handle it. There's one more contraindication. Well, there's a lot of them, but one more that we focus on. That little blue pill that some men of advanced age are quite fond of. Absolutely. Erectile dysfunction meds. All of that patient's blood pressure is going to end up somewhere other than their heart, and it's going to create more problems than we can deal with. In that ambulance. Again, we're going back to first do no harm. We get our assessment, we get their history, so we make sure that we're not giving them a medication that's going to do them harm. Oh, that's also interactions, but it's covered under a lot of points here. Why is it important to understand how medication will affect the body?
You just have to know how it's going to affect that patient before you can effectively give it to them.
Right. What might it change? What might knowing how that medication is going to affect that patient change?
I mean, it could lower their blood pressure, it could increase their blood pressure, increase their heart rate. There's just millions of things it could or could not do.
Absolutely. What it may change the dose we give them. You know, 80-year-old woman who fell and broke her hip probably doesn't need as big of a dose as, Mr. Army Ranger who just got back and is muscled to the max. We need to know our half-life so we don't give them too much too quickly. We need to know that Zofran, what does it affect? How does it work? Can anybody tell me?
It blocks the serotonin.
It does. So, and I keep going back to it because there's so many different things we can do to chest pain patients. Did I lose or gain one? Oh, I lost one. Okay. I didn't think I was that boring, y'all. Patients who are having STEMIs typically have nausea because of the vagal nerve that runs right through there. That's why they pass out. Lots of things happen to them. Zofran can have an effect on that as well. Don't ask me to go into the full mechanism of action. It would take me a week, and but if anybody wants to know, I will shoot it to you in text. It caused, we don't typically give it. We can give 8 milligrams. We don't though. We give them 4, or pediatrics 2, because if we overdose them on it, and yes, you can overdose on Zofran, they're going to have worse problems than when we gave it. So this is all stuff to keep in the back of your mind before you give a medication. And I will go ahead and tell you, if you do clinicals with me, before you ever push any drug whatsoever, you have to tell me everything about that drug. What the complications you may see from that and how you're going to fix them. Because if you don't have a plan to fix the disaster you could cause, you're not going to cause that disaster. And I speak from experience. Oh, look, we're back to first do no harm. I forgot that was there. Oh, yes, and don't forget, whatever they're experiencing could alter their body as well. Okay, so I know you said you hate math. I feel you on that, I really do. We're going to come back to that because we have some worksheets and y'all's stuff that goes over that and simplifies it a lot. We're going to come back to med math because that is not a good place for that slide. Who are you working under as an advanced EMT?
Med control, the medical director,
And who else? There's a whole long list.
paramedic if you have one,
Yep, who else? If you get in trouble, who's going down with you?
your partner, your boss, your company, your medical director.
Yeah. And I can guarantee you that 4 out of 5 of those people are going to pay a whole lot of money to not go down with you. So be careful what you push. But anyhow, it brings me back to you're operating under an EMS. We are constantly operating under someone else's license. They're the ones who give us, hey, y'all can't keep doing that to me. You're scaring me. They're the ones who give us our ability to practice, and they can take it away. You guys have seen the drug boxes. You are not new to EMS. You know the questions you need to ask to be certain of. This course is aimed towards EMS. I think sometimes they forget that not all of this applies. But you do need to know it for National Registry. Right patient, if you're transporting 3 patients, make sure you stick the fentanyl in the right patient or the Narcan in the right patient. Right time, make sure that you're not giving them a medication that they just took 20 minutes ago. As much as you can. Make sure you're giving the right medication for their condition. Make sure you've assessed them. All patients have a right to refuse. Unless they are, and forgive me for saying this, unless they are cuckoo for Cocoa Puffs and they have no clue they're on planet Earth, they have a right to refuse any medical intervention or assessment. Make sure you educate these patients about what you're giving them. You know, Zofran causes headaches. Nitroglycerin causes headaches. Aspirin can increase your bleeding. It's going to terrify them when that happens when they're already sick. But the last thing I want to come back to on this slide is make sure you're given the right medication. So many medications in our drug boxes look alike, have similar sounding or looking names, and can easily be mistaken. Check it, have your partner check it, and then you check it again before you give that medication. When you pull it up, you pull up the dose you need, you have your partner check it, and then you check it again before you give it. Pills like aspirin, nitro, those are pretty easy. These liquids that are, take fentanyl for example, 100 micrograms in 2 milliliters. 2 milliliters is a tiny amount. If you're only trying to give, say, 25 of that, and we've all done it, 2 a.m., nobody's brain functions on full blast. You go ahead and push that whole 2, and you give your 4-year-old patient 100 milligrams of fentanyl. That patient may be super, super happy, but there's going to be a lot of people that aren't. And that's if you didn't overdose him. All right. I'm trying to get back. Remember, I'm new to this program. This go-to meeting thing. We have standing orders from medical control in our protocol book, our SOPs, SOGs. If we need a medication we do not have an order for, contact your medical control officer. Make sure that you write down their name, write down what time, and repeat back to them what they've approved so that you know for sure. Because if he says, yeah, you can give them aspirin, and you hear atropine, you've got a big problem on your hands. It's a recorded line. If you can't hear them, call your dispatch back and be like, hey, can you tell me exactly what they said? Can you play it back for me? All right. Does anybody have any questions so far? You guys know a lot of this. I'm going to try and speed up.
Not so far.
Okay, awesome. This is about talking to medical control. You're familiar with this. You've been over it before. Everybody is a licensed EMT in here, right? I don't know Louisiana's policy.
You have to be licensed to level up, go up the rung, as they say.
Okay, I thought so, but I want to make sure.
I was a paramedic. Now I'm an RN. Now I'm going backwards again.
Oh, cool. You missed us.
Yeah, I did. I missed flying, and if you're an RNC, you just have a little bit more clout. So that's my goal, to go back that way.
Very cool. Very cool. Hey, Donald, did you have a question? Okay, awesome. You guys know about OSHA policies regarding workplace safety, needles, syringes, anything that could hurt you pretty much. We don't recap needles. Needles always go in the sharps container. Syringes with medications in them, no matter what medication it is, even saline, flush it, dispose of it in the hospital. You don't want to come back out to your truck and find the neighborhood, we'll say urban outdoorsmen addicted to mind-altering substances, licking everything in your truck. And it has happened. Document, document, document. Everybody used to say if it's not documented, it didn't happen. That's not entirely true. If it's not documented correctly, regardless of if it did or didn't happen, there's poor documentation is just as bad as bad documentation, or is no documentation. I'll put it that way. Especially as an RN, I'm sure you see that a lot. Okay, so looking at the meds, are there any medications on that list that you guys are not familiar with?
Nope.
Awesome. Did you guys do drug cards? Did he have you do those at the first of the...
Not in this class so far.
Oh, okay. They are very beneficial, especially coming up towards the end. It's something I highly encourage. It's not a requirement at this point, but I highly encourage it before you go to take any skills test. I've already told you I'm evil and will ask you about the drug before what just happened. Give me just a second. Something happened here and I do not have... Okay, there we go. All right. We talked a little bit last week as well about barriers that medications have to cross. This is big when it comes to their half-life and how they're absorbed by the body. Some medications can pass the mucosal barrier, like fentanyl and Narcan, especially, 2 drugs that we give up the nose. There's some that have to be given IV form because by the time they made it through the gastric system, they would be useless. We only have one medication we give fast, and that is paramedic level. That's adenosine. It's a rapid push. It is the only EMS medication that is given quickly. Everything else is a slow push or a drip. acids can eat up some of them, gastric acids, whatnot. That they move with anything you give IV is circulated to the through the body where it needs to go by the heart in the blood. So we need to keep them having good perfusion, good pulses, good blood pressure to get that medication where it needs to go. Except for medications that we give, that really only applies to IV medications that are delivered through the bloodstream. Okay. Electrolytes, patients, some of the sickest patients I've had have been severely dehydrated. That's been their primary thing. They've not had anything to drink in 4 or 5 days. That's going to mess with the electrolytes. It's going to mess with their sodium. We talked last week that the heart is a sodium-potassium pump. If they're dehydrated, their sodium and potassium levels are off. It's going to mess with their heart. This is stuff you're really... I wish we had 10 hours tonight so I could go into this deep, but we don't. Know that everything that happens to a patient affects something else in their body. Know how to fix it, what you can. Know your drugs and what they're going to do to this. Patients need fluids. Electrolytes, that's big with cardiac issues and dehydration and shock. And other things, but those are the big ones we look at. A lot of this we're going to go over in the next chapter too, so. I'm sorry, we're getting to the EMS stuff. Okay. So, back to dehydration. Causes diarrhea, vomiting, hemorrhage, insufficient intake, infection, fevers. A patient with a fever, and I guess technically I may be a little wrong about this, but it's a good way to remember it. A patient with a fever will always be dehydrated. They always need fluid because the heat of their body is throwing off their homeostasis. They're cooking that fluid. You know when you bring a pot to boil and you leave it too long and you look back at the pot and half the water is gone? Well, that's what's happening to these patients. Patients with fevers are always dehydrated. That does not mean they need an IV. Gatorade is a beautiful thing if they are not vomiting. Overhydration can happen too. They used to call there used to be certain torture methods that had to do with overhydration. Very painful, very miserable. We see it a lot in our renal failure patients and CHF patients. You will see a lot of dialysis patients going to the ER because they are overhydrated. They're edema. They've got urine pretty much coming out of their skin because their organs are shutting down. Quick example, salt. The salt goes where the water goes. If you've just eaten a bunch of salty foods, you're going to be thirsty. So if this patient, think of it as you just ate a bunch of, right next to me, sour cream and onion potato chips. They're very salty. I dare you to eat a bag of them without wanting a drink. So you take that drink because you have to dilute that sodium. If that's why we're seeing these dialysis patients who aren't following their diets, that's one of many reasons, in the ER so often. And I will just go ahead and tell you guys, they do not appreciate it when you give them nutrition advice like stop drinking 2 liters of Coke on the way to dialysis. Yeah, they seem kind of against that. All EMS fluids are isotonic. We only carry, all BLS and advanced EMT fluids are isotonics. Normal saline, lactated ringers, they have their purposes. We talked about them last week. You do not want to fill a burden patient up with normal saline. You do not want to fill a sepsis patient up with normal saline. Those patients need lactated ringers. Isotonic solutions have the same osmolarity as blood, serum, that's blood. Sorry, my computer screen keeps freezing up and there's certain places that I have notes on here. But if you are transporting a patient who needs fluids, pick the best one for them if you have the option. If not, they're all isotonic solutions and all of them should help keep your patient alive. Don't withhold fluid just because you don't have the optimal one. Okay, this goes into starting IVs. However, that's going to be a skills day thing. I know that's probably the most exciting part, and we'll come back to it if we have time and go over some of that stuff, because I have a really cool video about it. This is a pet peeve of mine. Before you stick, know where the veins are. Don't stick blindly. Don't stick something that you think you feel. It's not always a vein. But between now and these skills days, learn the anatomy of veins. That's going to help you a lot. Learn where they go, what valves feel like, because you want to stay away from those. Valves are going to be anywhere, and I know it's kind of common sense, anywhere you have a bifurcation. Can you see my pointer? Right?
Yeah.
Valve. So everybody wants to stick the AC. How many valves do you have in a very small space right there that you could end up hitting and not being able to get a good IV on this patient? Forearms are wonderful. Biceps are wonderful. Feet are great, but the hospital won't keep them anyhow. Oh, that's a lovely arm. Again, this is coming back to IV stuff. We're kind of breezing through because we're going to have to come back to it on skills days. If your patient has an infection, and I'm not being judgmental, I'm just going to be very blunt right now. If they have an infection from shooting up heroin in their arm, is that a good place to start an IV?
No.
No. But patients who shoot up can tell you where their good veins are, just so you know. And they're usually pretty spot on. Dialysis fistulas, stay off that arm. They usually will be wearing a bracelet saying, hey, do not use this arm. Mastectomies, we try to stay away from that side. We also don't take blood pressures on that side because the swelling in the lymph nodes, their bodies cannot handle. So this says, avoid any extremity that shows signs of trauma, injury, infection, or edema. EMS does not get called out to transport healthy, happy patients. Usually. The world's changing. If there's an infection or edema, that's absolutely 100%. We need to avoid that at all possible. If they have a broken wrist, and that is the only arm they have, or the only arm, the other side has a dialysis fistula or something. It is okay as a last resort to go up in the bicep and start an IV. You want to go above the injury, and you don't want to be taking that risk and bouncing out all over God's green earth trying to get that IV. That's my 2 cents on that. We're called emergency services for a reason, and sometimes we have to do things. All right. Drawing blood. The usual times that you will see blood draws in the EMS field is if you take a job with the hospital or you're there helping them out, and there is nothing wrong with that. If they get overwhelmed, we get overwhelmed. The second one is a little more complicated, and it's for law enforcement for blood draws to test for intoxication, drugs, whatever they need. We are not law enforcement. The patient still has the right to tell us no for that blood draw. You cannot assault a patient to get a law enforcement blood draw. If the patient says no, they have to take them up to the hospital. Or write it as refused the test. Those are great. It never looks that good. Before our skills day on IVs, know the ways you can hurt the patient with it. We do them every day. Usually everything goes well. When things go wrong, we need to, again, know how to fix it. You'll be sticking your classmates. Don't go sticking them without knowing how to fix what you may cause. Thrombophlebitis. Okay, I'm sitting here drinking an icy, so ignore my. That can happen pretty quickly. It's usually like the few times I've seen it have been kind of more long term, 15-20 minutes later. Or after giving high power medications like Phenergan, morphine, and a lot of it. Potassium's horrible, by the way. What you're going to see a lot of are occlusions, which the usual one is because the IV catheter is pushed up against a valve. Valves are ugly, horrible things. I hate them. They're awful. Or up against the side of the vein. As far as the actual catheter goes, there's going to be a lot more occlusions of the IV tubing. That is not on us, and that's an easy fix. Or the big occlusion is it can clot. Don't forget you can clot it. All right. Patients will pass out when you draw their blood or start an IV. We don't really use Trendelenburg anymore. Just kind of lower their head, make sure that they're cool. Pass out, vomit. Some patients, especially men, it seems like, do not have good reactions to needles. Scalp pains are great for young infants in the ERs. Most services don't carry a whole lot of butterflies. Does anybody know why we start at the hand and work our way up the arm looking for IV sites?
My old saying was, you use it, you lose it.
I'm sorry?
I always use the phrase, you use it, you lose it. So if you start high, you lost everything below that.
To keep it simple, yes. Because if we've made a big hole, I'm going to draw an arm. Okay, so this is our vein. And we've made a big hole here. What's going to happen if we start our IV right here to all that fluid going up?
I'll leak out the hole.
Yep. Theoretically, that hole clots, but that fluid can knock that clot loose and it can keep it from clotting. So then we've just turned our patient into a big old water balloon. Well, at least, you know, their arm. Good luck using a pen light. Make sure you protect your IVs if you get them. Oh, this right here is especially true for STEMI and stroke patients because they're going to give them blood thinners. And if you've made these holes, say you're not a very good stick and you've made 3 holes, that patient's going to bleed out. And I'm going to leave that at that. Okay, IOs. Our preferred location is the tibia. You can see here that you've got humeral head. We in EMS, there is not an EMS service in the continental United States that runs normal everyday 911 or transfer calls that is going to tell you to do a sternal IO. If you call for orders, there is not a medical director that is going to tell you to do that. We don't have the resources typically, and it's not, for the military it's great, for civilian EMS it is just not an option. Anything that you can give through an IV, you can give through an IO, with the exception again of Denison, because it needs to get to the heart so quickly. I don't recommend giving D50 through it unless you're going to sit there with a bag of fluids and give 5 cc's of D50 and then flush 10 of saline. And it's going to take you all day to get the D50 in them. However, if that's all you've got, that's all you've got. So, just to go over it really quickly, and I am sorry I cannot see all of this because of where my, there we go. There is a flat part right under your knee. If you reach down to your knee and you go to the inside, there is a little flat area called the tibial tuberosity. That is where we do our IOs at. This is also not a quick process because they're at much higher risk for infection, so there's a lot of cleaning, a lot of making sure that site is going to hold up for them. Well, that's not good. All right. All right. We have to be very careful with pediatrics because they still have growth plates. If we stick an IO into that growth plate, we can severely impede their growth. They are absolutely ones that the humerus may be better for. That IO, once you get it in, it's not going anywhere if you have it secured correctly. It's not going to get pulled out like an IV would. It's not going to have the patient moving their neck all over like an EJ would. It's in there. The conscious patients I have done IOs on have told me that it did not hurt at all going in. What hurts is when you start to push fluids through it. But it's only the initial fluid push. After that, they're fine. If you do an IO, you have to put a pressure bag on it. There's not a whole lot of flow there getting all that back to the heart. You have to put some pressure on it. As you can see the humeral IO site there. This patient, if he's having an IO in that humeral, he needs to be in the same position a patient would be for us to splint them for a clavicle or a shoulder fracture dislocation, with their arm tight against their stomach and secured in that position. This is sternal. We don't have those. It'd be nice. We don't. This is the most often location you're going to see. Just like that. You're going to go typically 2 to 3 inches below the bottom of the kneecap and find your flat tibial tuberosity. After you find that, you are going to clean like you've never cleaned before. Especially in the leg. People's legs are gross. I mean, they walk on beaches in nasty water, and that's for enjoyment, let alone all the other nasty stuff. Make sure if you have a conscious patient, or an unresponsive patient really, that your partner is holding their leg down. You do not want to start drilling and then jerk that leg. You may be the one that gets drilled. With the IO. These are manual IOs. That's what we used on infants at the first place I ever IO'd with. They're great. The patients don't like them because there's a lot more movement with them than there is with the drills. If you put headphones on your patients with the drills, they don't care. Typically. These are what we do sternals with. We will not be doing those. This is an easy IO, is what most of you will be using. Make sure when you get in the truck, every shift, that you make sure it's charged. The battery's good on it. It's ready to go. Because just like the drill in your house, battery's good, you need it, battery's gone bad. They are very loud. They sound like being at the dentist. We don't use guns. I don't know of any services that use spring-loaded. All right. These are contraindications. Okay, we're going to come back to that. Never ever give a pediatric patient a medication until you've measured them with a Broslow tape. You will be 100% sure that you have the right dose and you've calculated it all out right. And peds make everybody's heart rate go up. That anxiety can cause a lot of miscalculations, and their little bodies cannot handle miscalculations. Double check with the Broslow tape. There's a reason it's there. There's a reason that that company is making a lot of money for a lot of years selling those. The calculations for their dosages are the same formula, just smaller numbers. Like with Epi. No, I'm sorry. Again, all of these drugs are the same formula, smaller numbers. What does enteral mean?
Anything that goes through the GI tract.
You read the slide. You know better than that. What are some routes that are considered enteral?
CO.
Absolutely. What else?
Rectally.
Yep, that's also part of the digestive tract. Those are the two big ones. Most home medications are enteral medications. Do not use kitchen teaspoons to measure out medications. Every teaspoon is a different size. It holds a different amount. The rest of these are pretty good. When it says nipple, it is talking about a commercially manufactured one. You know how to give your own self medications. If you don't, please text me and we will go over that. You can assist the patient with their home medication. They need to be the one that actually takes it. Make sure they swallow and clear it out of their airway before you go moving them. All right, I'm going to hurry through this. There is a rectum. There is the syringe. The only patient you should ever be giving a rectal medication to is infants. Unresponsive patients, 90% of the time, except for some Tylenols for fevers, 99.9% of the time we can give it through another route. You are alone in the back of an ambulance with a patient. We do not, other than infants, do not need to be giving rectal medications. If you cannot get an IV on a diabetic, glucagon isn't working, that is something you can do. I would call for medical control. And again, that is a last resort option. And that is a horrible picture of a rectum, just so you know. Oh, be a nice person, and if you do give something rectally, infant or adult, use a lubricant. They're absolutely right. You can use endotracheal tube. It still has to be lubricated. It works great, though, as a delivery device. Don't pick the 9.0. All right, so we only have one medication right now that comes in ampules. That's going to be our Epi, 1-to-1. It is given for allergic reactions. We can give it IM for asthma attacks if it's a bad enough asthma attack that we cannot fix it other ways. But remember, when you give this medication, you're going to cause a problem somewhere else. So you have to weigh which is better, risk versus benefit. We use a lot of vials. We don't use multiple dose vials much anymore because we cannot keep them safe for patients. A couple years ago, they were giving flu shots at, I believe it was either Walgreens or CVS, using multi-dose vials and ended up infecting a lot. They were also reusing needles, but ended up infecting a lot of people with bloodborne pathogens. We use single-dose vials. We use a lot of pre-filled syringes. Our cardiac arrest epi is almost always in a pre-filled syringe. You guys can read the same stuff I'm reading. You can go back and read it. I'm, trying to hit on the major stuff. If you need me to slow down or go back over something, please let me know. This slide is slightly longer than I remembered. Reconstitution meds, Solumedrol, and if I remember correctly, magnesium are the two big ones we have that we reconstitute. Solumedrol is a wonderful medication that you will likely not see the positive outcome from. But you pop off that little top, up here, I don't know why I was pointing with my finger, y'all can't see that. Push down on the top and shake it. Then you draw it up like any other normal medication. Pre-filled syringes. These are the ones that you really, really, really need to be double checking, because you can reach for an epi and give an atropine, especially if they're not in their boxes. They feel the same, they look the same, they weigh the same. At 2 a.m., they may even look like they're spelled the same. And those boxes are not at all tamper-proof. I don't know where they got that. This we will be doing in skills. Okay. And I will post that in a moment. Is everybody still good?
Yep.
Okay. I'm going to pull up this next slide. Give me just a second. Oh, I'm going to show you this video real quick. I'm not sure what you can see right now.
Nothing.
Nothing? Okay, good.
Just basically the header for ARES Advanced AMT class. That's it.
Okay. All right. Give me just a second and I will have this pulled up for you. Of course it has. I know you guys have already been over a lot of this material, so it's kind of boring. But it truly is some of the most important stuff that you'll be doing. If y'all need a drink or to use the bathroom now, it's a good time. Oh, back. While I am pulling this up, another housekeeping note. When you got your book, did you activate your navigate access?
No.
No? Good. I'm going to give you a course ID. And again, while I'm pulling this up, if you want to go ahead and activate that and put in this course ID, it will bring you up to our classes page. And I just put in a lot of resources, study guides, stuff like that for you. Oh, and in there you also have all of the audiobooks and all of the PowerPoints and lecture note outlines. Let me know when you're ready and I'll give you that course code.
I'm ready.
You ready? All right. It is going to be 7, E as in echo, D as in dog, 4, A as in apple, 2. If you have activated Navigate, send me a message and I will have it pulled over. All right. Pulled it up. Ah, if I didn't open it. There we go. Okay. Here we go. Are you logging into that now?
I'm not Ducky because I watch all these classes on my phone, so it's kind of hard to do both at this.
Not a problem. I just want to make sure I didn't start if you were looking up something. All right. You guys ready to start with shock?
Go for it.
All right. Let's get this on. This one's a little more interesting. So we can have more fun with it. What everyone knows what shock is. I feel like they definitely hit it hard in the EMT course. We have a live trauma training, which covers a lot of shock. Of course, trauma is not the only way a patient can end up in shock, but we'll go over that throughout this. I'll have to speed up a little. Okay, so starting here. Shock is a state of collapse and failure of the cardiovascular system. The heart pumps blood. What happens if there's no fluid there to pump?
Heart fails.
Yep. Our body cannot maintain homeostasis. We don't get blood circulation. We don't get perfusion. We get no oxygen to the brain. A lot of bad things.
Hey, Ducky, are you supposed to have a screen up? Because all we got is a white screen, nothing there.
Yes, it's saying it's paused. I'm trying to figure out what's going on. PowerPoint open. All right. Oh. Give me just a second. Ah, there we go. Okay, can you see it?
Yeah.
Okay, awesome. Our bodies, you can't see it again, can you?
Yeah, I can see it, but we're like seeing your hose screen with the choosing slides on the left and all of your toolbar at the top.
Oh, okay, well, let's fix that real quick. Well, okay, there we go. So, like I said, there's multiple reasons for shock. What are some ways that, what are some things you may see your patient doing that goes, ooh, that patient may be in shock?
Sweating,
I'm sorry?
clammy.
Yep. They may be in a hot environment and shivering, like they're in Alaska.
Depending on the stage, their blood pressure could be elevated or decreased.
Absolutely. Their heart rates, all of their vitals are going to change. Their respiratory rate can go up. What is the absolute, this patient is in shock and we need to move now sign?
Bradycardia.
Close. Altered mental status in a previously non-altered patient. That level of shock, it's hard to get back from. At that point, they're hypovolemic, hypoxic, in an ugly, ugly state. All right. So we went over the autonomic and the nervous system last week. It controls the cardiovascular system. We have no choice. It does its thing. We can sit here all day and tell ourselves, heart, stop beating, heart, stop beating. Our heart is still going to beat. Our body takes care of itself. The sympathetic nervous system takes over more control during stressful situations. And to be quite blunt, I'm going to tell you how my instructor told me. You would not want to be running for your life in the middle of Africa with a cheetah chasing you, peeing all the way. He said it a little more interestingly, but I don't want to get fired on my first day. The parasympathetic.
What? What was that? Can you hear me?
Yeah.
What was that? I missed it. I just called. I don't want to get fired on my first day. I figured I would tune in a little bit more.
Oh, crap. Okay, well, you have to tune out a little. I'm just going to say it the way he did. The sympathetic nervous system is what keeps us from pissing our pants if we were running from a cheetah for trying to save our own life. It slows everything down. We would not be having diarrhea running from the cheetah because of our sympathetic nervous system. Our parasympathetic, rest and regeneration. Those are my two favorite words, y'all. Oh, when you come in to do your skills test, the sympathetic nervous system, everything we tell you about it goes out the window, because I guarantee you, you will get nauseous, you will get sick, and you will be running to the bathroom about 400 times. Happens to everybody. All right. So you guys have seen an anatomical body before. I feel like we don't need to. I have to move this screen. It's blocking half my thing. There we go. Regulation of blood flow. Our bodies know what we need, and they try and take care of themselves on their own. The heart, it knows when to beat. It knows how often it needs to beat. Not everybody's, which is where we get diseases and deformities. And not forever, especially if we don't take care of them. But a newborn's heart, it knows what to do. It does not need us to tell it. Okay. Computer is funded. Okay. So the heart is also, the lungs get our oxygen in and out. The heart, its beating is what carries the oxygen all around, up to our brain. When someone goes into cardiac arrest, you have 3 minutes before cellular brain death begins to occur, because the brain is not getting the oxygen. It's not the blood, it's the oxygen in the blood that the heart delivers. Coming back to shock, inadequate cardiac output. That's pretty much the be all of it. The heart cannot get out what it needs to keep our body functioning like normal. Except for neurogenic shock, but that's later on down the road. Our bodies initially, when we go into shock, especially traumatic shock, hypovolemic, our body tries to take care of itself, like I said. It's going to shunt all of our blood to what is most important to it. Our lungs, well, our brain, our heart, our lungs. And then the other organs as it can. When you go into patients go into shock, they can't feel their fingers. They can't feel their toes. It scares them. Their heart rate goes up. It has a harder time processing all of this, and they go further down the shock road. Make sure you are educating your patients on what's happening to them. We just talked about the blood. Its most important use is carrying oxygen and nutrients, but mostly that oxygen stuff. The blood tells us about everything that's going on in our body. It is a messenger system as well as a mail system. If a patient is in pancreatitis, how do we tell? We check their blood, because that pancreas starts giving off, we'll call them little dirt bags, that we check the blood for, and that's how we find it. That, and you have a miserable patient. Blood clots. The blood keeps us alive. It can also kill us. Patients with strokes, heart attacks, their blood clotted. We have hemorrhagic strokes, but again, talking about this, a occlusive stroke is a blood clot. A pulmonary embolism is a blood clot. A myocardial infarction started with a blood clot. Aneurysm, well, that's a tearing of the wall. But blood gets in there and clots up and puts pressure, which leads to the tearing. We have a lot of patients, especially in their 60s and 70s, who are on blood thinners because they can't afford to have any blood clots. I'll tell you a funny story about that later too. 60s, 70s, 80s, they have atrial fibrillation, which leads to blood clots in the heart. However, that's going to also make them more prone to hemorrhages, especially due to trauma, falls. If they're on blood thinners, they have to go to the hospital because they could have a brain bleed. They could have any number of things because they can't clot. Hormones, not something just in high schools. Our hormones affect how our body are little messengers that tell our body how to react sometimes. They work on the sympathetic and parasympathetic nervous system. Baroreceptors. They are the hey guys. Especially they sense that our blood pressure is going down. They send out these messages to the brain and the heart and everything else. Well, to the brain, and the brain sends a message back. Something's not right. We don't have any pressure down here. Think of it like a fire engine. They get on the radio and are like, hey, you need to turn that nozzle because we're losing pressure. We don't really look at systolic blood pressures anymore. We look at the map. Because every patient is different and vitals vary so much. But between 60 and 80 of a systolic blood pressure is too low for anybody. We want to keep patients at a MAP above 70. Hypoperfusion, low blood pressure, low heart rate, low MAP, blue fingers, blue toes, blue lips. They are not perfusing. Their body releases renin, angiotensin, aldosterone, and which causes them to release antidiuretic. That's going to cause them to not be able to urinate, to begin having edema. So this is, we talked about effects with medications. Well, the body has its natural effects as well. If hypoperfusion persists, so if the shock is getting worse, myocardial function worsens, tissue perfusion. At first, our heart was just shunting our blood from our fingers and toes. Well, now it's shunting the blood only to our core. So fingers and toes and arms and legs that aren't getting blood are dying. As soon as they stop getting blood, that area starts to die. It's a slow process, but it's one we need to take action on. Leak of fluid from the blood vessels, that can be internal or external. We have third spacing, which fluid gets in between where it needs to be and kind of gets stuck there. Blood vessels leaking out, that can be external. That can be, you were sharpening an axe and brought it down on your leg. Guarantee you're going to have some leakage there. If you're on blood thinners, you're going to have a whole lot of it. Our body naturally produces epi and norepi. No matter what they say to you, they could be allergic to the preservatives in it. There is nobody allergic to epinephrine. They would not be alive. We just went over that. So cellular ischemia, same as the heart, ischemia, lack of oxygen, decreased perfusion. And we're back to the sodium-potassium pump. All roads lead home. All right. Multi-organ dysfunction syndrome, also called multi-organ failure. I know you've had patients that they've said, oh, well, they're in renal, cardiac, and liver failure. That's because nothing that happens in the body, if left untreated, stays in one spot. Think about cancer. Even cancer, left untreated, you will get mets, or you can get mets, especially with lung and brain. Things in our bodies tend to spread. Infection, sepsis, if it's spreading to multiple organs, our patients are getting sicker. They're losing their volume. A lot of these patients are elderly. And a lot of elderly patients don't eat correctly because sometimes they don't have anyone to make them food, stuff like that. Their bodies are not prepared to handle this. We have to be able to recognize this. Multi-organ failure is not something they can come back from. And, you know, that can also happen with injury. Internal injury. Typical shock syndrome, or shock symptoms: hypotension, low perfusion, they're bleeding. Multi-organ dysfunction is before multi-organ failure, but they're on the same train tracks. Tissue is dying. All right. Y'all good? Uh-oh.
Yes, good.
Okay. Based on what slide we're on, I'm having to move all the screens around on my computer. So, causes of shock: bleeding, hemorrhage. Again, you brought that axe down on your leg and now you're squirting out blood. Respiratory failure. Allergic reactions. These are distributive shocks: infection, sepsis, multi-system organ failure is common, anaphylaxis. Well, anaphylaxis we just said. Which type of shock do you think it would be hardest to recover from?
Neurogenic.
Yeah, I'd have to agree with that. I was originally, distributive shock is because we fix obstructive we have surgeons that fix that all the time. Distributive, it goes through the body awfully fast, but neurogenics, yeah, I don't typically think of that one very often. A patient can go into shock from injuries that you cannot see. Multiple rib fractures, abdominal injuries, chest injuries. There is a lot of bone in the chest that can be broken and well hidden. Spinal injuries, we can touch their spine all day. We have patients every single day that complain of back pain that do not have any breaks, do not have any injuries. They're in one piece. And that yet we also have patients with spinal fractures that we can't feel, we can't see. So there always has to be that area of doubt in our head. Not doubt, of precaution. Severe infection, again, sepsis is the big one we're thinking of right now. Major heart attack, cardiogenic shock, anaphylaxis, hypovolemic, and non-hemorrhagic. Okay. Hemorrhagic shock, the blood is coming out of your patient and onto the surroundings underneath them. Non-hemorrhagic, all the fluid loss is within the body. Abnormal losses of fluids and electrolytes, a very bad stomach infection, somebody's been vomiting and diarrhea, they have no fluid left in them, these patients can still go into shock. They don't have enough to maintain their homeostasis. Sweating. I've never seen somebody go into shock from sweating, but okay. Pancreatitis, very common one. Burns. We see patients go into shock all the time from burns. The good news is we're teaching people how to be safer with fire, so we're seeing less actual burns. Diabetic. Renal. Earliest signs, restlessness, anxiety, complaining of thirst, clammy skin, like you mentioned earlier, high heart rate. Blood pressure is kind of a late sign because that is when our body has realized it cannot fight anymore. It has been compensating this whole time. Now it can't, and so the blood pressure starts to fall. Cardiogenic shock caused by inadequate function. It's a pump failure. I don't know if you've talked to some of your cardiac patients, but cardiac patients love to tell you what their ejection fraction is. Oh, I have 26%. I have 18%. Y'all are in bad shape. This is a pump problem. Their heart just can't work anymore. Obstructive shock. Cardiac tamponade. Tension pneumothorax. PE, pulmonary embolism, blood clot, big obstructive shock. Notice how there's a theme with obstruction and our body not liking it. Distributive shock. This distributive shock can be caused by a lot of things. Most of the ones that we see are infection, that type of thing. But there are other things that can cause the widespread dilation. And then back to the one you mentioned earlier, neurogenic shock. Damage to the nervous system. Just stop right there. It's damage to the nervous system. It's going to make the blood vessels dilate to where they cannot keep the pressure up that they need. The problem with that dilation is the increased size is not giving us the preload or the output that we need. Right. Think of distributed shock as it's free flowing around the body. Anaphylaxis, bee stings, cinnamon for me. Don't bring cinnamon around. You'll be treating anaphylaxis. This is the type of shock that most people forget. Psychogenic shock. A patient has a bad mental reaction to something, pretty much, that causes physical symptoms. They faint. Tell a man that his wife is pregnant with 10 babies, and I guarantee you he's going to go into psychogenic shock. We mentioned compensated shock earlier. Our body's still fighting. It's still in the running. It's not giving up. Our pulse pressures, you'll hear the phrase narrowing pulse pressures and widening. That's simply our systolic pressure minus our diastolic pressure. I keep forgetting every time I click on the thing, I have to click on this. Decompensated, that's late. That's when our blood pressure has dropped. That's when we have altered mental status. You may be getting ready to do CPR on these patients. And the thing is that is only a 30% drop. Just 30%. 30% seems tiny in everything else. Irreversible shock, the patient is going to die. That's, at that point, we have to keep them comfortable and do what we can to minimize their suffering. All right. Y'all good? We got 10 minutes to get through, not very much more.
All good.
Good? Awesome. Scene size up. Remember that you can't help anybody if you get hurt. Your life, your partner's life, your patient's life, and then anybody who's outside of that triangle. So let's run through this, just tabletop it real quick. Everybody take yourself off mute. Okay. So you have we're just gonna do a shock patient assessment. You are dispatched to a call where the patient is complaining of headache, weakness, and that's really all the information you have. You respond on scene. There are no hazards. What are going to be your initial survey?
So the scene safe. How many patients do I have? What's my nature of injury, mechanism of injury or nature of illness?
Okay.
Do I need help?
You have one patient. You have, the only information you have is this patient fell earlier, and ever since he's been getting weaker. He's got a headache, and he's starting to look a little pale to his family, and they just want you to go in and check him out. There's no hazards. If you want help, you can request them.
How does the patient look just besides pale? Does the patient have raccoon eyes? Can you get more of a description of like a general feel?
Yeah, so the patient is pale. He's a little diaphoretic, really. He moves his eyes to look as you enter the room, but he doesn't move his body at all, and you know it's what to do.
All right, I'm going to go ahead and start treating him for shock. Start him on some oxygen. Get him warm. Blanket.
Okay. Is there anything else you'd like to know about this patient?
Yeah, I mean, I'm gonna do my entire primary assessment, get his history, and find out if he's on any blood thinners, any kind of medications, have any allergies.
Vital signs?
When was it last normal?
Okay, so remember that your sample and history and all of that is actually not a part of your primary assessment, but we are going to go ahead and go through that. Vital signs, his blood pressure is 80/50. His heart rate is 112. What all vital signs would you like?
Well, at the BP level right there, since it's so low, I would try to get an LS unit in a route. If not, life flight.
Okay. Is there anything else you want to know about this patient?
Respiration.
His respiratory rate is 24. He looks to be about 70 years old.
What is his quality of breathing? Is it shallow? Is it fast? I mean, of course, this is 24, so it would be fast. Is it deep?
It's fast, it's deep, but it's not really, it's not loud. You don't hear any rails or crackles, anything like that. It's just normal breath sounds. It's just fast and deep. What else? What you thinking?
I'm gonna go ahead and start him off on mode 2.
Okay. What was his pulse ox?
Hadn't asked for that yet.
Okay. All right. Well, that's okay. That's why we do tabletops. His pulse ox is 95%.
Okay, so he's got good review. I'm gonna start.
Are you okay? You're not driving again, are you?
Oh no, I'm sitting at my table in the kitchen.
Oh, okay.
I'm thinking.
Good, good. I want you to think.
I'm gonna start him on probably simple face mask, 12 liters.
Okay, so you do want to go ahead and start the oxygen?
I do,
Okay.
and I'm basing that on what you told me that he fell earlier, and my mind is going down the possible hypovolemic shock that he's 80 or 70, fell, possible hip fracture with internal bleeding.
Okay. Well, you have your differentials there. Let's go back to, I'm sorry, Donald. You were asking about his sample history. Hold on, I had to get my magic pen out to do this with you. So he fell about 2 hours ago. He, since then, he didn't initially complain of any pain. His son helped him up. He seemed to be doing okay. He got him into bed to rest for a little bit. And the patient started complaining of headache, weakness, and just kind of went downhill from there to the point now where he's having a hard time getting him to respond to him. His allergies are morphine. Hold on. Are morphine and penicillin.
Can I play?
Blood sugar.
What did you ask? Who?
What's his blood sugar?
This is Rob. I was going to say, can I play in this game too?
No.
All right.
Okay, so his blood sugar is 186.
Non-diabetic?
Yes. His going back through the sample just real quick. His medications are lisinopril, Lasix, potassium chloride, and Eliquis, and metformin.
I got a quick question. How far did he fall?
Oh, standing. He tripped over a rug.
So this might be a diabetic emergency, not necessarily a injury to the brain per se.
I mean,
I would probably steer away from that. His blood sugar is not that high for non-diabetic. He is on blood thinners. He's on blood pressure medicine. He's on antidiuretic.
all right, yep. Going on with your sample. Past history, you pretty much gleaned it. He, has hypertension, diabetes, CHF, AFib, all the things that most 80-year-olds have. And his last oral intake was he fell an hour ago, about 45 minutes ago, when his son brought him in some orange juice.
All right, so what led up to this event? Was he just in the house walking around? Was he outside doing grass? You know, what happened before he fell?
He got up out of his recliner, went to go to the bathroom. On his way back, he stumbled over a rug that wasn't secured down and fell.
Okay. Gotcha.
So, what other questions do you have? You guys are thinking, and that's a good thing. I want you to find a path to go down. Donald, what did you say about the diabetic thing? You were talking about this may not be a brain injury. What did you mean?
I done forgot.
Okay. Well, that's okay because you're gonna have people on scene making you forget too. I do it all the time. I keep notes. I tape them to myself. All right. Okay, so your actual exact comment was, this may not be a brain injury, it may be diabetes. What are you basing that off of? Or were you?
Based on a few things. One, the fall. I mean, granted, he is 70 years old, but I don't see the patients. I can't say if he's a healthy 70-year-old or is he kind of an invalid 70-year-old. Also, his blood sugar was 187. I don't know what it's normally supposed to be for him. So I'm just trying to get some more data in and try to make that assumption.
Well, ask questions. I'm your patient. Interview me.
I think Donald's doing a great job.
I think he is too, but this is a team effort. Don't make her do all the work. That's not nice. You also have the option to phone a friend, your medical director there, number 4, if you need to.
Hey, Rob, chime in for a minute.
But you can only ask him questions. You cannot ask him for answers, for general answers.
All right, this would be good because I tuned out, so I don't know what's going on. So this will be
Hey, that's normal for medical directors too.
Yeah, I was about to say
Okay.
the med director's not going to know. What you got?
Med control. This is 514. Have a 70-year-old male. Blood pressure 80 over 50. 112. 24 breast per minute. Statin at 95%. His blood sugar is at 186. He is non-diabetic. Hypertensive. Congestive heart failure. Started him on some O2, 12 liters per minute. Considered starting an IV of normal saline. How do you suggest?
Give me his blood pressure again. You kind of cracked out on that
80, 80 over 50. Yeah, he had a fall about 3 hours ago.
one. Okay.
Yeah,
I would.
Blood pressure is now 60 systolic. You cannot get a diastolic.
So blood pressure has crashed lower to 60.
All right, absolutely. Give him some fluid. Give him saline. Try to maintain a pressure of at least 80.
All right, so I'm going to go ahead and start IV. He's got good veins. I'm going to pop an 18 in.
You have a blood pressure systolic, but continue. I get what you're saying, but don't expect good veins.
Nah, this is just hypothetical. So he's going to be a perfect patient,
Yeah.
So he's got good veins. I'm going to start 18 gauge right forearm. I'm going to start him on normal saline. I don't know his weight. What's his weight? And we want to actually, you want me to calculate how his drops per minute here, or are we just going to wing that for now?
That's up to you, instructor.
Yeah, that's what I was asking Ducky.
Oh, I'm sorry. He's a 160-pound male. And you are alone in the back, or you and your partner are alone in the back of the truck with this patient. What you do to him, I cannot tell you.
I'm going to mute and go back to work.
All right, so I've already started his IV, normal saline. Since I don't have my calculation page pulled up, I'm going to just run it at about 50% open.
What is it, hun? I didn't hear you.
I said I'm just going to run about 50% speed. Honestly, I don't have my dosage calculation. That part of the chapter pulled up to calculate that.
Oh, your fluid? You don't have to tell me
Yeah.
anything. Just tell me wide open or keep vein open.
Okay, all right. I'm not going to, that's what I said. Do you want me to actually calculate it? Because that's what but I don't want to run it wide open, but I don't want to TKO it either. So probably 60%.
Okay. Are you still there, Donna?
And I don't want to run. I don't want to run him wide open because he already told me he has the history of CHF. So I don't want to fluid overload him any more than he already is. But I do need to increase his blood pressure.
Absolutely.
If I can.
Okay, so is there any other information you would like?
Let's see. So I started by IV, started an oxygen, having him go ahead and load him up, keeping him on treatment shock. I'm going to rest test my vitals now. It's been more than 5 minutes.
Okay. All right. Donald, do you have anything to add?
No, ma'am.
Okay.
You're killing me.
Huh?
You did a great
Killing me.
job. Perfect job.
All right.
Yeah.
I don't want to be alone.
No. I want to see you did you rocked it.
Well,
You've got a patient that fell. You got a patient that fell, most likely trauma, even from a standing position. Sorry, the elderly can crack a hip and they can bleed out without ever putting a drop on the ground. So your blood pressure dropped. When it comes to trauma, textbook, we want to keep at least a minimum systolic of 80 if you can. And with the fact that he, I think it was a male, is possibly bleeding out, then that's what you're fighting. So time's not on your side. You're not going to fix the problem. They're not going to clot. The more liquid you put into them, the less they're going to clot. So you really need to get them to a hospital. But to stop them from going into irreversible shock on you, absolutely, you gave them oxygen. You gave them fluids. Your goal is to maintain their blood pressure. That way you can kind of help that compensated shock continue. Because you don't want it to go decomp on you. And once it gets there, it's really hard to get them back. In fact, especially as AEMTs, a lot of the stuff that the paramedics get to play with, we don't. So you're a little bit better off than the basic, but you're still limited in what you can do. So yeah.
You know what? As soon as Donald walked in and heard that blood pressure, he was like, we may need ALS. Let's get him en route, which is a great choice for this patient because we could give him dopamine if that scenario had called for it.
Right. Yeah, in fact, if the fluid doesn't work, usually dope is the next step. So you'll need a medic for that.
Yep.
And that's why I said right off, do I need help? And he told me I was the only one. That's kind of not what I meant. I meant, do I need help as in additional resources?
Yeah. Well, I always, when we do these tabletops, we are not doing them national registry. We're doing them to make you think about, what do I really need to do for these patients?
Right.
Assess your patient and make that decision.
Real life.
Robert, real life. The skill sheets and stuff, that's for national registry. When we're doing lecture and talking like this, we're figuring out how to treat our patients. I'm kind of mad at Robert right now because he took away most of the good things. Like, he picked up on all of those. You guys asked a lot of really good questions, and I'm just talking over Robert because I'm mad at him. But there is a couple of things I want to point out that I'm not fussing at you. I just want you to think about them because you don't realize what you did until they're the reason football teams have to watch their game plays. They have to Monday morning them. So let's start with, and I mentioned it a couple times because I really wanted you to focus in on it. When you said this may not be a brain injury, it may be diabetes. That's good that you're thinking of what it could or couldn't be. But you never asked if there was any trauma to his head. You never asked what his injuries were. You never asked if he had any injuries. You went, did he fall? Yeah. Okay. A patient can fall and stand right back up. A patient can fall and die. This guy
Well,
to the side.
I did ask for more of a general impression of what he looks like, and then you start going on to where it's kind of sweaty, diaphoretic. So at that point, I was thinking that you would hold maybe a little bit more than that, like if he did have injury to the head. So I didn't, my bad for not elaborating a little bit further, but when I, asked for a more general impression, that's what I was trying to get at.
I get what you're saying. This patient had no external trauma. He hit his head against the side of a brick fireplace. No external trauma that you could see. However, he is on Eliquis, and people on Eliquis tend to bleed. His blood pressure was dropping. Something you will see with a lot of head injuries, stroke, any in the brain, they're going to go.
Hey, Ducky, I can't hear anything you're saying. There's so much feedback. I can't hear you.
Yeah, Donnie, mute your mic do me a favor, buddy. Mute your mic. It's a lot of your background noise.
Okay, you good? I stopped hearing it. Did everybody else?
Yeah, I can hear you.
Okay,
Yeah, you're
perfect.
good now.
When you have any kind of brain injury, strokes, aneurysms, seizures, blood sugars go up. If a patient is presenting like a stroke, I'll take that blood sugar for two reasons. One, to rule out that it's not low. And two, if I see a blood sugar in the 180s, 190s, it kind of tells me something's going on with their brain. Typically. I try to make it a little easier by saying that, he had also just had a cup of orange juice, just to try and get you to rule out that blood sugar.
I did rule it out. At first, I told Donald not to have the ball, so I don't think that's the issue.
Yeah, no, and your team members, talk it out amongst yourselves. Feed off each other. Don't feed off bad ideas from each other, but feed off the good ones. Yeah, that was great. And again, I'm not fussing. I'm just pointing out that way you can review,
Definitely, I like to constructive use. You suck to criticism a lot.
Especially since this is our first run, and I feel like you learn more from going, ooh, I should have seen that, than you do from listening to a lecture. This patient has the typical history that our patients have. He's on the typical medications. He's getting lethargic. This isn't particularly a patient I would want to move around a whole lot before I got some fluid in him. But that's just me. Some people like to load them up, get them in the truck, and then start their fluids. I like to put a little juice in them before I go shaking them up. You jumped on the sample history. You got a good 18 gauge IV. This is a type of patient that you can easily do bilateral lines, assuming he has bilateral extremities. Saline, I think you did great with that, right with the oxygen. Typical standard answer for that is I would give him a bolus, check lung sounds, and then bolus again. They advise to start out at 250, but with this patient, there's nothing wrong with a 500 bolus. Is there anything else you guys have to add? Anything y'all noticed?
I noticed it's awful hard when you can't really see somebody.
Oh, absolutely. It is. Especially, and veterinarians are the best doctors on earth because their patients can't talk to them. If you have a patient, even that you can see, who is nonverbal or has whatever else going on that you cannot get answers, you cannot, see their body the way it's supposed to be for an assessment. You can't put your hands on them. Certain cultures, if you're a female showing up for a male or a male showing up for a female, they're not going to let you touch them. They will accept transport, but you cannot touch them. They get very offended. So, and that's kind of one of the good things about oh, sorry, I was reading. One of the good things about the tabletops is you really learn to think without seeing. So you can think about everything without a distracting injury. He's right about the head pain, which I went over that in the beginning. He was complaining of a headache. Neurochecks, fingers, toes, check those. This patient's going into shock. He's laying there, he's shivering, he has a headache, he's not really responding. I would definitely add some warm blankets, warming that fluid up a little. Nothing wrong with that. But other than that, like, y'all did great. You really did, especially considering this was the first time. So how would you transport this patient to the hospital? I know you traditional.
If possible, I would probably see if I could rendezvous with a P truck, or like Donald said, depends on where we're at, maybe AirMed. But with possible head injury, I may not want to fly him.
Great.
So it's all depend on our location and our transport time. If I'm 5 minutes from the hospital, I'm gonna unload and flow.
Well, let's back up a minute, and this is entirely my fault. What type of hospital does this patient need to go to? Does he need to go to Pearl River Community Hospital?
I have no idea what that is. So if it's like my Beauregard Memorial, negative. He probably needs to go to a more high advanced trauma center.
Oh, go.
It's not trauma. It's higher level of care.
What were you saying, Rob?
Oh, she's from DeRidder, so she's way away from Pearl River County. I was saying Pearl River Community Hospital is a Band-Aid station. They are stabilization only, and that's about it.
Yeah, I went in there and asked for a Band-Aid. They didn't even have that. They also didn't have my allergies.
I'm not going to knock the nurses in particular, but I'll say they don't know the layout of their crash carts. We went in with a code once, me and Mike Barnes, and they couldn't pick out the difference between epi and atropine in their crash cart.
Okay, I reiterated what I said about the knowing your meds and double checking.
Rob, they are a stroke center now.
This was years ago, dude. Because I try not to knock anybody individually. I won't ever call names. And this was probably 10 years back. So I don't know. I mean, they may have gotten a lot better. I just know that at that time they had just opened up their ER, and they weren't used to it. It was still very much like a old folks home. It was still 99% of the building. So
yep, it is. I took a patient in there last weekend. They have 2 ER beds. 2. 1, 2.
My patient probably does not need to go there, but I'm gonna see how my interventions are gonna work. If that's my only choice, maybe my only choice.
Okay. It's a clear night. No bad weather, or a clear day. No bad weather. However, there is no ALS units available. Everything in the county kind of went to crazy right when you got this call. There's no ALS units for Intercept. What's your next option?
Like, is air available?
Absolutely.
Roll them, request them. Especially, where's my next facility? It's 45 minutes up in, let's just say hypothetically, Mobile.
Yep, that's, your nearest trauma center is a good hour. I'd even go say so far in some parts of this county, say an hour and a half away. Level 1 trauma center.
I'm gonna probably try to see if I can get him a helicopter ride.
Yeah. Those guys love doing it. It makes their day. Absolutely. Is there anything you would want to make clear to the accepting caregivers of this patient? I mean, you give your report. Is there anything you want to make certain to say to them?
Yeah, other than the normal vitals and what I have and what I did. You know, what seems like we're kind of going down the head injury line. So what is the LOC? Is, you know, pupil reactions, is motor function.
And don't ask me about pupils because I'm half asleep right now. His pupils are a little bit dilated, but otherwise normal. His LOC, he's very lethargic. He responds with grunts. If you ask him a question, he grunts at you. His son said he went hunting with him that morning. He's normally very active and with it. Does not grunt at people.
I know a lot of people love them. I absolutely hate them. That's just one of my peeves, but maybe a GSC.
I'm sorry?
So a lot of people love these, and I absolutely hate them. I don't really grasp them, but glioblastoma still.
Yeah. Yeah, they can take a while to get used to. But the good news is, in just about every charting system, it brings up the whole scale for you so you can pick which ones you want. And you can open that up and look at it, or even put it. I keep a binder with all that stuff in case, my brain's gone crappy. I can just flip open that binder and get my calculation. Glioblastoma.
Speaking from a orthopedic nurse standpoint and doing a lot of surgeries, one of my main things that I have to know is blood thinners. I need to let them know that this patient is on a blood thinner. If he possibly has a head injury, he's going to bleed out like this.
Absolutely. That's kind of what I was getting at. Especially if you're going to fly him, because they have a lot of, or I don't know about a lot. I know some air services carry blood products, and that is absolutely something they could decide to start on him. Which, I mean, the blood thinners aren't so bad for that, but you want to let them know. If he crashes, goes into cardiac arrest, this isn't particularly a patient that, being on blood thinners and Lasix and potassium, that they're going to be able to do a lot for until they can get him to the hospital and get him the medications he needs. But always plan 2 steps ahead. That's not really part of first do no harm. It's kind of lastly, make sure nobody else does any harm. You guys did great with making sure the scene was safe, interviewing the family. Oh, look. He's not perfusing. I think, at this point, you guys have really grasped on to all of that. Is that helpful? Does that help bring a lot of the stuff we went over together, doing stuff like this for you?
Yes, definitely. And we still can't use a monitor.
Huh?
We still can't use a monitor, correct?
No.
Ugh, stupid.
No. Rob and I were talking about that today, and I'm going to get back to you after I talk to him later. Just exactly what his policy on that is. And remember, everything that in class that you're authorized to do, you are not cleared to do on your own on a truck with a non-preceptor yet. Just because it's in.
I'll say, since I'm here, I am fine. We can train them by all means. Learn the monitors. Just know your scope too, because some states may allow you, especially as advanced EMTs, to use the monitor. But as for example, in Mississippi, even though near everybody and their brother uses a monitor as a basic on the truck, it's technically out of your scope. So by all means, learn it. We'll teach it. We'll talk about it. I'm fine if you do that. Just as students, understand that you're still manual blood pressure, and really and truly, I mean, that's a good habit to have anyway, even if you can use a monitor. But yeah, just know that some things like spiking the bag, we all do it, but it's technically out of our scope, that kind of thing.
Yeah.
Becky and Robert, this is kind of what I was thinking about. I had a call the other day, and I know we're talking about war stories, but it plays into what I'm thinking here. 17-year-old kid, MBA, fire department, city municipality was there. I was the first on scene. No ambulance support at all. They had their monitor, and he was running everything off of the monitor. He stuck a nasal cannula in, which is also anyhow that's what he did. And I said, "Why are you putting that on? You know, that does no good. I'm checking her respiration." Did a manual blood pressure, pulse off, and he's telling me like, "Punch this button, punch this button." I'm like, "No, dude, I don't know what the hell you're talking about. I don't even know your machine." That's my point. You know, if you have a basic knowledge, if a paramedic says, "Punch that button to get my blood pressure."
Absolutely.
Yeah, and you got to keep too. Sometimes those monitors can be wrong. So even if you can use it, like I said, I would always get your baseline manually and then go to the.
I was pulling my blood pressure cup out of my junk bag, but he's like, "No, I got it off my monitor."
Yeah. If there's something else I need you to be doing, I will stop you and be like, well, let's get this, see how it looks. We can come back in 5 minutes and get these vitals if there's a life threat. Because we treat life threats before we go down the rest of that road. You know, if this patient had an open hemorrhage that was arterial and squirting everywhere, we need to get that bleed stopped before we worry about what his numbers are.
She had a femur fracture, but it was closed. But it was an obvious femur fracture that he never addressed.
Oh, wait, why?
You tell me. Now, I mean, like I say, I was acting as Donna Travis citizen at the time, you know, so I really couldn't crash his party. But
Okay. Every paramedic.
I just picked up on all the things he I don't know, he might have been new, but he was shaking like a cat in the little rocking chairs. He focused right on starting 2 large bore IVs and not so much like you said the life threat. But and I said several times, hey, she's got an obvious femur fracture, you know, we might want to do something about that. She's got bloody, frothy sputum coming out of her mouth. You had suction, of course, theirs did work. When Acadian finally rolled up, their battery was dead, so I rolled her on her side. That was the only thing I could do. Yeah.
You can only do what you can do, but I will say this, and every paramedic in the continental United States is going to hate me when I say it. You are first and foremost a patient advocate. Even if there is not a medical treatment in the world, as a nurse, as a paramedic, as a physician, as Senior Medical Director Robert Roy, if there is not a single medical intervention you can do, you still have the right to be that patient's advocate. And I'm not saying you did anything wrong. I'm just saying don't be afraid to say, hey, wait up a second. You know,
Oh, I said it. I said it, but he didn't listen. And like I say, I couldn't
well, that's all you can
jump
do.
his shit.
Yeah.
I didn't jump his shit because I was coming home from my nursing job, off duty,
Yeah.
witness the accident.
You don't have to jump people. You can, just find out what their reasoning is. And sometimes, like, just like in these tabletops, it's, oh, I saw a rabbit hole and I started running towards it and I completely missed the den of vipers 2 feet away from me. Distracting situations. But, that I told Robert, the biggest thing for me is how we treat our patients ethically, humanely, compassionately, and as their advocate. They are our children.
I like these situations because you tell us what we should and do, and what you shouldn't do, and what you didn't do. And to me, in the end, that makes me the person. I don't want to be that paramedic that I worked with on the side of the highway. I want to be the opposite.
I'm so proud of you. It is equally important to learn how not to be from some of these medics, especially the ones, I call them baconators because they're very crispy and salty. Don't be a baconator. But yeah.
I want to be the Mac Daddy.
There you go. Extra cheese.
Yes, extra cheese and expertise. I don't know what you just spelled.
I like that even better. But yeah, so and if you're standing up for your patient, I can guarantee you other people will stand up for that patient too. But yeah.
As I another useful, about to call it the when she was bloody, frothy coming out of her mouth, the sheriff deputy that saw the food sign.
Wait, this patient had bloody froth coming out of her mouth and he did nothing for her?
Suction wouldn't work. So I said, okay, let's roll her on her side. So the SO deputy that was on scene didn't know how to do that. So I'm going to take over for you. When I took over for her, I had C-spine and 1, 2, 3 roll her. When I rolled her, basically her head just above her temporal region where I was holding C-spine was like mush.
Ew. Ew. Okay. Well, I wasn't in the truck. I didn't see what happened. Based on what you're telling me, it may be, I don't even know, honestly. I've seen some people do some things that still to this day, they did it 10 years ago, and I'm still scratching my head going, why on earth would you do that? This kind of sounds like one of those moments.
And kind of, to defend the guy now, the first response unit was the city fire department. The little guy on there is a paramedic on the fire department. He's not on the truck. He doesn't fly 911 calls. He's just first responder. But as a paramedic, he probably doesn't have a lot of oh shit moments.
Yeah. Those, they get very used to, how do I put this? Paramedics such as that spend a lot of time in classes doing refreshers. They learn to do the bookwork. They don't get a whole lot of hands-on life lessons, I call them. So they don't know when to alter what the book says with what their brain and gut say. Because that's something that's built up. You don't wake up one day and, have great instincts over something you've never done. It takes a lot of practice and a lot of seeing of things going wrong. That's how you learn. So it may, he may have been just trying to follow the book and not inserting the hands-on, brain-on mush. Yeah, right. I like that, Robert. Especially when we click through online refreshers and don't actually read them, read the updates, or pay attention. Okay, what is that? Oh, yes. Oh, you can learn something new every day. For example, did you know? I found this out the other day. A patient can be banned from the hospital for smelling so bad that he made the nurses physically vomit and refuse to shower.
Interesting.
Yeah, I learned that one last night. That was a pretty good one. Yeah, he made them physically run out of the room puking. It was great. I was just getting over COVID. I had no smell. Okay. Well, hey, Donald, are you still there? I see your number, but I don't see your face or your voice.
Yes, ma'am. I'm still here.
Oh, okay. Do you have any questions? Anything you want to add? Anything relatable, unrelatable?
Nope, I'm good.
Okay. Do you have the Navigate with your textbook, or did you access it already?
I've already accessed it. I listened to it on the way to work.
Oh, okay.
They have a audio book, sort of audio book. It's not that great, but it works.
Yeah. They use the cheap speakers. Yeah, they've got a lot of resources, and the one I have set up has a lot of extra stuff in it that I found useful. I was just gonna give you guys access to that if you want it. Oh my
Yeah,
God.
I'll definitely load it up when I'm not talking to you on my phone. Like,
Yeah, definitely.
sticks and don't have Wi-Fi and stuff like that.
Yeah. I know you may not want to say it out loud in front of the group, but before you leave, make sure to send me your information so I can get the group chat going here.
What kind of info?
Oh, well, just your name and email address and phone number, and I'll load you in here. I don't think I have access to that.
Gotcha.
Hey, Robert, quick question for you if you're still there.
What you got?
Do I need to save this meeting link before I do anything, before I stop recording? All that?
I'm sorry, save the what?
It says, do you wish to save this meeting link?
Oh, that's new. I don't know. I haven't seen that one. I would say no. As long as it's in the recording, just know that your recordings don't show the chat.
Oh, okay.
So, yeah, keep that in mind. The recordings are only going to see your slides,
Oh, okay.
which is good. So people watching the recording don't see Donna's information there.
I said not.
Well, yeah. I mean, like if you ask a question or if somebody puts something in chat, you'll read it out loud. That way the people watching the recordings can hear it.
Okay.
Other than that, no. Meeting link, I don't know.
Okay.
I would say
I wasn't
no.
going next week or Thursday.
As long as we get the recording, that's what matters.
Okay. All right. Well, so I know Thursday. On Thursday we have BLS, I believe, to go over, which I really, really hope y'all remember the CPR course you just took.
Yes, definitely.
Huh?
Definitely do.
Okay, awesome. So that shouldn't take too long. We'll just hit the low notes.
Hey, Ducky, just FYI, we haven't worked at my nursing job all week because we're iced in. Literally, it looks like snowpocalypse around here. We're going to try to work till 7 o'clock Thursday, so I may be on a little late.
All right. Well, thank you for letting me know. Definitely. And yeah, I completely understand. There was something else I was waiting to tell you too about Thursday. Well, if I can't remember, it must not have mattered too much. Okay. Well, we went over just a little bit tonight, I believe. But I want to make sure you guys have everything you need. I believe we start medical assessments as well on Thursday. So while we're going through the different parts of the body, we'll be doing more tabletops if it's beneficial for y'all. And if you have, watch what your partners on the trucks are doing. Watch how your patients are responding. Watch how they interview them. Now, I'm not saying to repeat what they do because I know what some partners do, but watch, learn from it. Pick up things that you want to incorporate into your own method. Things that you don't want to. Bring it up, say, hey, I saw my partner do this and it was great, but then we did this and, you can learn a lot from watching. Also, be asking your partners if you can start interviewing these patients because that is you've got your skills going from EMT basic to EMT advanced, but you've also got your increase in responsibility for the patient and a whole other job description going on there. You becoming the advanced, if you're the highest level, you don't have a paramedic, you have a basic with you. You are the authority on that truck. You are the one responsible for getting a good interview of that patient, making sure you're asking all the questions that need to be asked. And that does not come easily, and it does not come naturally for a lot of people. Some people it does, but because you can't stand back and watch anymore. You have to be actively involved. Think on the way to the call, what do I want to know about this call as soon as I get there? What do I need to know about this patient?
Hey, Jackie, I have a kind of a question about that. But
Go for it.
I guess I don't know if it's a question. I'll just say what I'm thinking. I kind of have I don't know, what I do say, like when I'm going to a call, I think out loud, but I'm also thinking out loud to my partner with you to feedback. Like, I think I'm going to do this, I'm going to do that, I'm going to do this, this is what I have, this is what I'm going to do, this is what we ought to do, what do you think? And I'm asking you, what do you think? Maybe say, think with me or think against me. Not necessarily that I'm going to agree with you, but.
Yeah. It's bouncing ideas. Bounce ideas before the call, bounce ideas after the call. It was back in January. We went to a call where there was 3 pit bulls that did not look at all happy to see me. My entire attention was focused on them. It's the middle of the night. I couldn't see very well anyhow, and I had 3 big pit bulls coming at me. I don't like being bit. I'm not a big fan of dogs I don't know. They tend to push me over. That's all I was focusing on. After the call, my partner was like, "Hey, wasn't that peacock at that patient on that patient's porch pretty awesome?" I looked at him. I was like, "Are you crazy? There's no peacock there." He was like, "Yeah, it was sitting right on their front porch, or preening, or whatever it is that peacocks do." I never even noticed it. So you notice different things. You notice different things about the patient. You notice different things about the scene. Bounce everything off each other. Listen, you would not have any situational awareness either if you had 3 big old pit bulls coming at you, looking hungry.
Oh, they probably just wanted to lick you.
Oh my goodness. No. I don't think so. They had the "you're going to be kibble" look going on. Yeah, the guy actually, not the patient, but the patient's son-in-law came out shooting a gun off to scare the dogs away. I was like, yeah, that I'm kind of glad I kept 2 eyes on these 3. Okay, do you have zero fear or just a reckless endangerment going on there? Got bit twice 2 weeks ago.
By the same dog on the same
Oh,
scene.
I love dogs, but no.
What is a Chihuahua? Who was that?
Oh, yeah, that's not getting bit by a dog. That's
Not really.
a barking cat.
Hey, I got to step out for a bit, so I'm probably going to miss the end of your class, but I wanted to add something, I guess, for you guys specifically with the advanced EMT. As of March 1st, we're getting new checklists from the registry. I haven't seen them. I don't expect them to be anything really majorly different, but hopefully they're written a lot better so I can get off my soapbox about them because I'm always ranting. So I'm going to replace those as soon as I get them, and we'll start working with those to get you guys ready because that's what you're going to wind up being tested on when it comes that time.
Okay. Well, so that's definitely something we'll want to practice, especially if, we're changing things from from what we're used to doing, because you know all these refresher courses, they do their assessments just like you guys started to, based on those National Registry skill sheets. Oh, that is something I was thinking just a minute ago. Nobody said anything about taking C-spine.
I did.
You did?
I did.
Oh, I'm sorry, I missed that.
Yeah, like right out the gate when he said he failed.
Oh, okay. Okay, I'm sorry, I missed that then.
I might have said it a little too
Yeah.
lightly. Try not to follow.
Nah, these guys are gonna know their stuff. They're not gonna be cookbook. They're not gonna know their line numbers. No. These guys already know their stuff.
They do, but they got to get through the testing portion too.
Oh, absolutely. But you tested like 40 years ago and you still know the line numbers.
That's because I teach it. I didn't know it until I started doing that.
I love how he ignores everything else I said there.
No, I just selective hearing.
Gotcha. I'm just giving you a hard time. Anyhow. Okay, so nobody has to hang up at all. I'm going to stop the recording there because I feel like that's a nice long recording for people to tune into. But remember, class, on Thursday, try to actually
Don't stop it.
course.
Yeah. Give your give the code before you stop it. Sorry.
Code?
Yeah, for the night, the PIN number, so they can do their attendance.
What PIN number?
You make it up, but it needs to be. You need to let me know what it is too.
Oh.
At the end of every class. I thought y'all did this last week.
We did.
Okay.
Yeah.
Okay. Before you start recordings, make up a PIN, 5 digits or so, whatever. It's up to you. And everybody will use that to log their attendance, so that if I ever have to run a report for the registry or the state or whatever, I can see who was in tonight's class.
Okay. All right. You guys ready for your PIN?
Shoot.
3825. If anybody can tell me what that spells on Thursday, I'll give you a lollipop.
Say that again, Justin.
The PIN is going to be 3825.
Yeah, I got that, but you said something about lollipops on Thursday.
Oh, yeah. If anybody can tell me on Thursday what that spells, I'll give you a lollipop.
Okay.
All right. Oh, final thing before we end the recording. Looking at live study days, refresher, information, catch up. I believe we had a request for weekends. I am completely available the 27th and the 6th, if either of those days work for everybody.
27th of February.
Yeah, the 27th of February, 6th of March.
Yeah, 27th of February, I have fire department driver training all day.
Ooh, fun.
And March 6th is on a Saturday. I'm waiting on a KDN to give me some final information about that day. So that it may or may not be. But after the 6th, that should be my very latest thing I have to do for you.
Oh, okay. I think I go
But
back.
I don't rule the world. I'm just saying.
Yeah, well, that's the last Saturday I'm off. But we can work something out. It'll just have to be text. I'll just have to text it out because I've got to look at this calendar and see what Rob needs.
Okay. Sounds good.
Yeah.
Just with a, I work a full-time job. I can't miss during the weekday.
Oh, one more point. I know I keep saying one more and then giving like 5 more. That being said, I am doing a Stop the Bleed class for the neighborhood on March 9th. If anybody is available and wants to come and bleed out for them, you are more than welcome to. I know some of you are coming from pretty far away. It will be here in Poplarville, Mississippi. I'm not sure of our turnout yet. We've had quite a few say they're coming. I just need people willing to come and bleed out. And I promise not to take your own blood. Probably.
What's your time?
Oh, it's from 7 to 9 p.m. 7 to 10 p.m.
Gotcha. I'll do my best. Like I said, Poplarville is like 4.5 hours away.
4.5?
Yes, ma'am. I'm in DeRidder, Louisiana, which is 40 miles north of Lakeville.
Oh my goodness, I didn't realize just how far you were. Holy days.
Yeah,
Okay, I'm suddenly very happy about this virtual stuff.
me too.
Alrighty. Well, we'll virtually add you to the class. We'll get you a little virtual tourniquet.
Cool.
Okay, yeah. All right, I'm going to stop the recording there because I feel like we've ventured pretty far off course. All right. Remember, the pin is 3825. All right. And we are stopping the recording.